Hi folks, welcome to our video on general anatomy of the head and neck. So this video is going to be a bit like an overall or a catch-all for the head and neck. We're going to have specific videos that come out on specific parts of the anatomy that we don't cover in this one. We're going to detail some of them on the next slide. So let's go to that now. So basically anything in this list is going to be covered in its own video or in part of another video. And so I'm not going to touch on them now. Just for the sake of avoiding overlaps. But this should cover pretty much everything else that you need to know about head and neck anatomy. If there's anything that you feel we've missed or that you're unsure about, feel free to message us about it. I also want to touch on just briefly before we get into it, in terms of how to approach head and neck anatomy, because it is, often touted as one of the harder parts of year two, and it's obviously an important one to get right. So the first and most important thing is to just make sure that you are doing what works for you. So there's no catch-all thing. You shouldn't be following a prescriptive view of how to practice it. If you found something that works for you over the past year and a half, then stick with that. At the same time, what worked for me, at least in terms of approaching head and neck anatomy, was to sort of think about it in terms of chunking. So I would try and find something in terms of either space or function, some way to organize different elements together. And I found that much more easy than trying to remember everything at once, because you just can't. There's too much content. And so I found it a lot easier if I was able to separate things into defined, sort of areas and then dive into each of those at a time and understand them in relation to each other. And I would discourage you guys from rote learning stuff. There are a couple summary tables in here. They're good references, but I wouldn't try to just memorize them unless you're really out of time, because ultimately that knowledge, leaves your head much quicker. And if you want to remember this stuff, the best way is to actually understand it on a deeper level. All right, enough faff. Let's talk about this. Okay, so the skull we're basically talking about two major parts of bone. Everything above the mandible is fused together, and then the mandible is separate and articulates with the rest of the skull. Obviously, there's teeth as well, but we don't really touch them in medicine, so we're not going to talk really very much about them at all. And so you can understand it as everything above that should be fused together. It doesn't have any joints or articulations except with the neck and with the mandible. There are some connections to the hyoid bone, which we'll talk about later. That's not really a joint because there's no articular surface and there's no really movement with it. But yeah, one thing you'll notice as you look at this, there's a lot of, obviously there's the actual brain case inside the skull itself. That's really a biggest enclosed space. And actually a lot of the stuff in your head isn't fully enclosed by bone, as much as it seems like a very big voluminous thing. Your eyes, to an extent, obviously there's a big hole in the middle at the front. Your nasal cavity also has a big hole, but it's pretty well covered. But then your mouth really has holes everywhere. It's not really fully enclosed by the skull. There's plenty of boundaries out to the outside. And so really, if we think about it, your nasopharynx and your nasal maybe not your nasopharynx even, your nasal cavity right at the front there, which is, if you see there, it's made up by mostly our ethmoid bone, also a little bit of a nasal lacrimal and a maxilla. All of those together form that. And then your ear. So you can see there, the outside part of the ear, the external acoustic meatus, the ear canal, and then the internal acoustic meatus on the inside, that's also an enclosed sort of space. But everything else, when we talk about these nerves and stuff, we're basically talking about things that exist in the fleshy part of your head. And so a lot of the pathologies that we talk about can result from damage to that area. And so we shouldn't think of it as all being, this big impenetrable fortress. Okay. Yeah, you sort of just have to memorize this stuff. There's certain parts that I'll single out and we'll talk about. Yeah, and hopefully it makes it a bit easier. So let's talk about the cranium. So these bones are, to me at least, the easiest parts to remember because they all just make like a big sphere basically. Whereas a lot of the bones at the front, they make this, big complicated structure. And so the way that I find it easiest to understand is basically just that your parietal bone, the orange one there, or really your parietal bones. So like most of the bones in the skull, though not all of them, the parietal bones are twinned or paired. And so we have one on each side. And that goes for your temporal bone. Pretty much anything that's not in the middle, it has to be paired because otherwise you wouldn't have two of them. And so the parietal bone really makes up the big majority of the cranium. And then we have the frontal bone, easily named. Occipital bone, I think once you sort of get it a little bit, it becomes really easy because basically everything involving the eyes, except for the actual eyes themselves, is located to the back. So your occipital bone, occipital arteries, the there's muscles as well that are called that have occipital in their names, and those are involved in elevation of the, sorry, not elevation, extension of the head and neck joint. You basically could have a pretty good guess that anything in that, base of your skull region posteriorly is called occipital something. So you shouldn't have too many issues with that. Your temporal bone. We're going to talk a bit more about the temporal fossa in a moment, and that'll hopefully make it easy to understand that. The sphenoid is really, it's really buried in there. You can sort of see it over there, just sort of inferior and anterior to the pterion. That's a really weird one. We're going to pull that out to have a look at it later because you really can't see it very well in this view. Everything else you can sort of see how it fits together. It makes this big arc, and then there's a sides here. The sutures you just need to sort of remember. And again, I think a really pretty easy one is that every single suture involves the parietal bone. And so we have a coronal at the front, your sagittal. Those are, they're literally, if you think of your coronal plane and your sagittal plane, that is pretty much just the same thing. Then we have a couple ones that are a little bit more difficult, but not that tricky. So I wouldn't worry too much about it. Okay, so the temporal fossa, this is pretty high yield. So I forgot to mention with the pterion. So the anatomical significance or clinical significance really of it is that it's a pretty weak point. So if you sort of feel in there, it sort of sticks out a tiny little bit. And it's also a fusion of about 4 bones. Both those things make it a little bit more susceptible to fracturing. And that's not good, obviously. We want to maintain the integrity of our brain case and our brain. And so we worried a little bit about the pterion fracturing when we have trauma to the side of the head. But the pterion is only one structure inside this big sort of depression called the temporal fossa, which you can palpate on yourself if you're so inclined. And so most of the boundaries of the temporal fossa are made up by the brain case because a lot of it is just an arc on the brain case. But then we get involvement of this bit at the front called the zygomatic arch. And so that's sort of the bit, you can also palpate that. That's sort of the bony bit where you can see how it makes the edge of your eye sort of rim, your orbital rim, as we call it. And that makes up the inferior anterior border of the temporal fossa. And so the temporal bone, most of it makes up, it's sort of flat along the brain case. It makes up a large portion of that structure. But then we also get a process over there that called the articular tubercle. Can't pronounce things today, which comes out and it joins the zygomatic bone, which is the one at the front over here, goes back, they form the zygomatic arch together. And so the boundaries of the temporal fossa are the temporal line, the superior temporal line. There's an inferior temporal line just below. The boundary is bounded by that and superiorly, and then inferiorly it's bounded by the zygomatic bone. And so you're going to want to know all of the bones around the region. And this is mostly significant for, you'll see a little bit about fractures and hemorrhages later on. And it's also the origin point for the temporalis muscle, which is involved in mastication. Yeah. And also note, so the sphenoid bone, it's actually fully inside the temporal fossa. So you don't really need to consider it part of the boundary, but it does form part of the surface in there. Okie dokie. Let's talk about the sphenoid and the ethmoid. So these are 2 ones that are sort of buried in there, and you can't really see them under the normal view. So hopefully this is a little bit more understandable. They sort of look insane. So bear with me. So this bit at the front here, sorry, this is the anterior view. So we're at the front looking at somebody, and you can see here that the sphenoid sort of has 2 big wings, and that's really I guess the most important thing to understand about the sphenoid is that structure. So we have the greater wings on either side with these tiny little dinky things that we call the lesser wings, and those are really more significant when we're thinking about the cranium itself, and less significant when we're thinking about actual attachments because they're smaller. And then the other things I'll draw your attention to really are the pterygoid process is the biggest thing, and lateral and medial plates, because those have some significance in terms of attachments to muscles, as we'll see with the muscles of mastication later on. But I guess the important thing is to understand its structure. So really, it's the wings form the front part of the brain case, and then the sort of sphenoid crest, it extends out forward, and it actually meets the ethmoid, which is the next thing we're going to talk about. And the ethmoid, it's sort of almost like, I don't know, like a tiny little rhino or something, where if you look at it, we have the crista galli, which is sort of that little bump, and that's anterior. And there'll be a bit of significance to that later on when you talk about neuroanatomy, but we'll leave it for now. And then at the bottom, we have this thing called the cribriform plate, which is going to be important as well, because a lot of stuff relating to, surprise, surprise, your nose runs through there. You can almost think of it as, it's almost like a little prism, like a little thing you can imagine slotting in to the skull. And so it's most easily understood as like this little rectangular prism. It had all of its walls, all of its interactions are flat surfaces, so it makes part of our the roof of our palate. It then forms the bottom of part of the brain case, and then the sides make up the medial parts of your nasal cavity, basically. Okay. And yeah, those are the important things to understand with that. Okie dokie. So cranial nerves, these are important to understand. We're going to be referring to them many times through this video, which is why I thought we'd stop for just a second to understand what they are and what they do. We're going to talk about the root of some of them in particular. Eventually, you're going to need to learn the roots of all of them to some extent. We're going to focus on the ones that are most high yield and most clinically relevant. So some of these are quite straightforward. Like basically, if you look at 1, 2, and 8, they are literally just their senses. So 1 is your smell, 2 is your sight, 8 is your hearing and your balance, and that's all they do. And they come from the places that give you those senses: your eyeballs, your nose, and your ears. Some of them are also very one-tone. So your 3, 4, and 6, oculomotor, trochlear, and abducens, all they do is they move eye muscles. And so they're pretty easy to remember. The ones that are more complex and more difficult, the ones that probably focus most on are trigeminal facial, and vagus, and to a lesser extent the glossopharyngeal nerve, because that's also a little bit tricky. It's a bit less high yield though. So at the same time, the vagus we don't talk that much about in the context of head and neck anatomy. We will talk about it when we talk about the pharynx and larynx, but in terms of stuff up here, it doesn't really feature that much. So yeah, so odd numbers plus 10, 5, 7, 9 are going to be our more complex ones. And you'll really see that when we start talking about what you can see here already. They're the ones with mixed functions. So unlike some of the ones I talked about before, where it's just a one-note thing, they actually do a lot of different things. And so we need to understand that, and they go to a lot of different places. Ignore the nuclei for now, like the rightmost column. That'll be important later, but we're going to have a video on that. So don't worry about it for now. And now just hopefully this is a decent overview. Take it in a little bit and we'll be reinforcing it as we go. All right. Okie dokie. So let's talk about the skull. So the orbital region, or the orbital rim, the orbit itself is just what we call a little hole for the eye. And so the orbital rim in of itself, we get the frontal bone at the top, that's in red, the zygomatic bone in blue, and then the maxilla in orange. However, you will need to also know the contribution of the ethmoid bone, you can see there in purple, the lacrimal bone, and the sphenoid. Those are the other important things to understand as they relate to the orbit itself. And pretty much more importantly, you need to know the openings inside it, okay? So I think it's easiest to understand it as the optic canal, the fissures, and then the foramens are basically extensions of the fissures. So the optic canal, it's, again, pretty straightforward. So it just does one thing. It carries the optic nerve and the ophthalmic artery. The optic nerve does one thing, it carries your eyesight. Okay, so that's pretty straightforward. It's just that. It also carries the ophthalmic artery, which is important because it provides most of the arterial supply to this region. The superior orbital fissure. So we get a lot of different things here. So we get innervation for the extraorbital muscles of the eye. I think that should be extraocular because they're definitely inside the orbit. But that's basically, we're going to think about like a 3, 4, and 6 cranial nerves, because all they do, remember, is control the eye muscles. Carries part of the trigeminal nerve, specifically the ophthalmic division. Surprise, surprise. And it carries the superior branch of the ophthalmic vein as well. And so that's going to be part of our venous drainage. Again, the inferior orbital fissure we get instead of from the cranium. So the optic canal and the superior orbital fissure, they came from the brain case into here. They're coming from above down. The inferior orbital fissure, it sort of looks like it might be the same sort of thing. It's not. So it comes from a very different place, the infratemporal fossa, which we'll talk about later on. And it comes from down there up into, and so it has a different sort of place. We get different neurovasculature involved. Everything that comes from there goes back down. And that hopefully is a bit useful later on when you come back to this and think, okay, what was coming through here again? That's right, it has to be stuff that comes from down there inferiorly. And again, so the supraorbital and infraorbital foramen, they transmit structures that came through the superior and inferior orbital fissures. So this, you can imagine them almost as extensions that allow those things to then go forward and innovate or supply or drain stuff that's on the face itself. Okay. Also, the supraorbital foramen, you'll sometimes hear it called the supraorbital notch, because it's not a full foramen in some people, so you might just have like a little notch here, a little hole. It's sort of like, yeah, a notch, a groove in your orbital rim, and then the structures will flow through there. Not really particularly clinically important. All right. This is all just stuff that's more useful as a review thing than for me to go through now. Things I'll draw attention to. So I should clarify the trigeminal nerve. So we call it the trigeminal nerve because it has 3 major divisions. So the ophthalmic division, the maxillary division, and the mandibular division. So you can sort of think about their relative importance / function by the things that they're named. So the ophthalmic division is going to have stuff to do not really with the eye, but with sensation around the eye region. The maxillary division is going to have stuff to do with sensation around the maxilla, which is just the main bone that makes up most of your face. So ophthalmic, sort of maxilla. And then your mandibular, your mandible's down here, so it does sensation to there. It also does a bit of motor innervation, which we'll talk about later in the video. I mentioned the pterygopalatine ganglion there. We'll cover that a bit more when we talk about the pterygopalatine fossa, infratemporal fossa, and all of that sort of stuff. But yeah. Okay, quick sort of detour here into skull fractures. Probably should have put this earlier in the video, but in simple terms, so we can get an orbital blowout fracture, which is what happens when you fracture the face and then you mess up the orbit. So the orbit is sort of this little pocket. It's meant to be pretty integral, meant to hold everything inside there. If we fracture it and stuff leaks out, they'll get issues. So if you think about it, and you'll understand these sinuses more when we actually talk about them, but in simple terms, you can leak into whatever sinus is closest near you. The biggest thing that you need to be worried about, and really the only thing that you need to be concerned about, apart from maybe just a brief like understanding the symptoms, is understanding the risk of the superior leak. Because basically, what is superior to your orbit? Your brain, right? So superior and a bit posterior. If there's fractures in that direction and stuff leaks, and most importantly, we fracture the brain case, because remember, a lot of that rear wall of the orbit is made by the sphenoid bone, and that makes up part of the brain case. So if you mess that up, then your cerebrospinal fluid, which hangs out there and is meant to be buffer for the brain, might leak out. That is not a good thing. Or it might get infected. That's an even worse thing, because that means it spreads all throughout excuse me, the brain case and the brain region in there. Trapdoor fractures, another just like small little thing. Basically, kids' bones very stretchy, and so if you break one and it comes back, it's like opening a door, and then you come back and you catch like someone's coat in it or something, and it gets jammed in them. And so in this case, instead of a coat, we're talking about a connective tissue or muscle. The muscle is the easiest thing to spot. So a kid might come in, they've had some trauma to the eye, and then now one of the eyes is stuck up like this. Even if they try to look around, it sort of just sits there, maybe moves a tiny bit. That would be because one of the muscles of the eye is stuck up there, and they can't move anymore, basically. Yeah. And so you don't really want them to be stuck like that forever, because it's bad for the muscle and it's bad for them. Okie dokie. Yes, so we are going to talk about cranial nerves again because they are important. So I talked a lot about things like different branches of the ophthalmic division of the trigeminal nerve and whatnot. This is where we talk a bit about like what those things actually look like. So you'll see here, we talked a bit about like the lacrimal nerve, the frontal nerve, all of those things. This is what they actually look like. So I'm sort of repeating myself. The lacrimal nerve is most like, as its name might suggest, it goes to the lacrimal gland there. You can see that sort of pink thing there. And so you can see that its function is not going to be entirely sensory or even mostly sensory. It's actually involved in stimulating that gland there. The frontal nerve over here. So again, really all of these things are connected. So think frontal nerve, frontal bone. Where's the frontal bone? It's up here. Okay, and so this is going to provide sensory innervation to the frontal bone up there. Hopefully that sort of thinking is a little bit helpful for you guys. I'll draw attention also. So the inferior orbital groove is this little sort of bit here. You can see the maxillary division coming through here. So it just hangs around here. All of the superior alveolar nerves, basically that anything alveolar, that's just teeth. So you'll see like alveolar process. That's just the little bits that let the teeth get seated in there. Alveolar nerves, they're just nerves to the teeth. And so you can see how the ophthalmic branch splits pretty quickly. And then the maxillary branch, instead, it sort of potters its way along, going. And then it gives us some branches through the infraorbital foramen, as well as innervating the teeth over there. But they're primarily, both of them, sensory. So they bring back sensory information from mostly the superior surface of the skin, but also from inside. Yeah. Okie dokie. Let's talk about the mandible. Most of the important things that you need to know here are marked. One thing that I think this diagram does miss out is the neck of the mandible. So typically we talk about the neck as sort of this bit here. It's sort of just below the condylar process before it joins the main ramus of the mandible. And that's relevant sometimes because you can get fractures there, or you can get this or that. The things that I think are important for you to remember, so condylar and coronoid, don't get them mixed up because obviously they serve different functions. The condylar is the thing that actually articulates with the rest of the skull, whereas the coronoid sits over there and provides a bit of a counterweight attachment point, whatever you want to call it. I will say also there's sort of a canal here, so the mandibular canal, the inferior alveolar sort of neurovascular package, it enters here. It doesn't exit out of the inferior alveolar package. You get the mental nerve and artery. So again, everything is connected. Once you learn these words, you'll be able to just get it straight away. So if you think back to your respiratory examination, I think they teach it in. You might remember doing like the submental, submandibular, blah, 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 lymph nodes. Mental just means chin. Okay, so it goes in as your lower teeth, inferior alveolar, artery, vein, and nerve. Then it supplies all those teeth, and then it comes out as your mental nerve because now it's going to supply your chin. So it's all connected. Yeah, hyoid bone also hangs out there. So remember, there's three really moving parts to this thing, although the hyoid isn't really considered part of the skull for reasons that you will see later. Okie dokie. So this is all a big mess of information. Stay calm. Don't worry about it. The most important thing I think here is to find a way to organize this in your head. So for me, at least, the way that I found was to, like I said, chunk it a little bit. And so I would think okay, so the anterior cranial fossa is this bit over here. You can sort of see the anterior, then the middle over here, and then the posterior, so it's a bit lower. So they sort of step down. So the anterior is also most superior because it has to sit on top of your eyes and your nose and all that. And so anterior really is not very much of importance. So you have your cribriform plate, which you should really start assessing with the nose. And that's just going to transmit your olfactory nerve. So that's just smell. So you can think about, okay, well, the all of the only thing important there is your nose. And so all of the nerves have to go through there. We've already talked about the greater and lesser, sorry, the lesser orbital, inferior orbital fissure is not going to be here because it doesn't come from the brain case, right? The optic canal and the superior orbital fissure will, however. There's a group of little foramen in a group in the middle cranial fossa, which is really high yield to remember, and that's the rotundum, which you can sort of see here as a little fat circular one, the ovale, which is the one that looks like an oval, and then can you guess what the spinosum one? Well, it's the long one that looks a bit like a, I guess, if you really argue, a bit like a spine. And so those three are very high yield. They talk about them a lot because a lot of important structures go through them, and so you want to make sure that you remember them. Yeah. In terms of how to remember, like in terms of remember which one is which, I think that should be like the thing I said before should be pretty easy. So they sort of elongate as you go. The one that's most like a circle is named after a circle, rotund. The one that's an oval is named after an oval, so on and so forth. Yeah. So that should be a bit more straightforward. Remembering how what actually goes through them is a little bit more tricky. But you can remember that this is all the trigeminal stuff. So we're still hanging out with cranial nerve 5. And because the ophthalmic division is too cool for these guys and has already gone through the superior orbital fissure, we're left with 2, 3, and then a specific branch of 5. Over at the back here, internal auditory meatus is very important, as is the jugular foramen and the foramen magnum. So foramen magnum, your spinal cord, all your big important stuff. Your internal auditory meatus, most importantly, your facial nerve, because it goes through that whole sort of ear area, but then comes and supplies a whole lot of stuff around the head and neck. Your ear nerve, because of course it goes through there. And then I'd say maybe the hypoglossal canal, but only in the context of, well, the hypoglossal nerve. Yeah. A little thing that I'll mention here, because I don't think we mentioned elsewhere in the video, is that most of the cranial nerves are called the cranial nerves because they're meant to originate in the cranium, right? So they start in the brain and then they go out. Rather than starting in the spinal cord, which is what everything else does. There is one of them that is a lie for, which is the accessory nerve, and that was thought to originate in the brain, but it actually turns out it's a trick of anatomy because we didn't really understand how things work back then, and so it actually starts at, I think, C1 to C3, but don't quote me on that, and then it goes up. It enters through the foramen magnum, so I can't really point to it because I've got my neck in the way, but it comes up with the spinal cord, or like spine in general, comes up through there, enters through the foramen magnum, and then it goes back out through the jugular foramen. So basically they found it coming out of the jugular foramen, and they're like, oh, this is a cranial nerve because it comes from the, if we go and trace it, we'll find somewhere in the brain. And then they dissected a bit further and they realized, oh, hold on, this doesn't come from the brain at all. But it was too late because they already said all the numbers, and I guess 12 was a nice round one, so they didn't want to change it. But yeah, so know where all the cranial nerves exit, if nothing else. If it doesn't carry a cranial nerve, mastoid, foramen, and condylar canal, nobody cares. That's not important. Know all the cranial nerves, know the big, internal carotid artery, jugular vein, although that one's hopefully pretty easy because it's named after, the foramen is named after the jugular. But yeah. And then little tip. So your middle cranial fossa carries your 2 to 6. All of those except for the trigeminal, which is 5, are eye nerves. And so they all just go through optic canal or superior orbital fissure, which leaves only trigeminal divisions to come through the main area. The anterior cranial fossa is nothing important except for cranial nerve 1. And then your posterior cranial fossa has all sorts of guys down here, but with time you'll be able to remember those two. Okie dokie, so cervical spine. The most important thing to understand here is the first 2 vertebrae, so the atlas and the axis. Atlas is the Greek guy who holds up the world, and in this case, because med students have very large heads, it also holds up our heads. So the most important thing to understand is how they actually articulate together. So you can think of it almost like, if you ever played like, not horseshoes, but that game with like you throw the rings onto the pole. I don't know, like I can't remember what it's called. But the point is, you can obviously rotate that ring around, right? So it forms a different sort of joint to anything else in the body. And you have the odontoid process of the axis underneath that comes up, and it provides basically a pivot for the atlas to be able to slide around in a circle, rotate this way and that, without coming off, obviously, because we don't really want it to be scraping all the time. Because if you think about it, that joint would be like arthritis central, right? If you had a joint there that was just like a plain joint, it would also be really stiff. And so this is the best solution that we have. So you can just sort of go very easily. We've got the sort of whole anterior arch and then the transverse ligament of the atlas. They hold it in place, and they hold it in place firmly enough, along with all the other, soft tissue viscera in the area, that you never need to worry about that sort of thing, obviously. Specific things of the cervical vertebra, there's a few different features. Biggest thing I draw your attention to is we have the vertebral artery, which is, it's sort of cool. It looks very, I don't know, cyberpunk, I guess, going through the all the foramina. Unfortunately, that means you can get a vertebral artery dissection if you get damage to the spine, because it's right there inside the spine. And so if you mess up those vertebra, then it can be very bad news for the vertebral artery. That's about all I have to say about that. Okay, skull ligaments. So there are not very many of these. Why? Because there's not many joints, and ligaments really have mostly to do with joints. So we'll start with the neck, actually. Most of this is stuff you already know. So if you think back to all of the stuff we learned about the spine, these are all just, those ligaments. The one that is unique to this area is the nuchal ligament. So it just sort of sits there. You can actually feel it on yourself if you go back. And that's the unique one. So that's only found on the cervical spine. Everything else we find in the rest of the body as well. Rest of the spine, rather. In terms of ligaments in the skull, so pretty much all of these have to do with the temporomandibular joint, which is obviously between the skull and the mandible. It's the only place where they actually articulate. And then there's your stylohyoid ligament just hanging out at the bottom there, unloved. But pretty much all of these are named by the two things they're connected, so hopefully they're very easy to remember. I'm trying to remember why I wrote down the sphenomandibular. Oh, sorry. The sphenomandibular ligament is sort of, you can sort of understand it a bit as it's like one of the big hinge or pivot points for the mandibular joint. So obviously it articulates with the temporal bone, but it can actually do this thing called gliding forward. We'll talk about it, I guess, a bit more. We might touch on it again when we talk about we've already touched on, okay. Talk about it now. So you open it, and that's just your normal joint. If you keep on opening it further, you'll find that it actually stops rotating in that region, and it glides forward. So it actually moves as both our initial sort of vague ball and socket joint or something like that, and then it becomes a sort of plate joint or facet joint, and it actually slides forward. And so it's more complex than just thinking of it as a hinge. It can actually do quite a few things, which is a bad thing if things get, stuck or trapped or fractured, because it can mean that, specifically there's a thing called lockjaw, where if you extend it too far, which hopefully I'm not going to demonstrate for you guys, you can get it stuck in a position where it can't actually be pulled back. Excuse me. All right, let's talk about vasculature. So I'm not going to touch the internal carotid artery because that's really more neuroanatomy. That's all stuff that supplies primarily the brain and the spinal cord, with the one exception to everything else being supplied by the external carotid, is that your excuse me, ophthalmic artery comes from that whole little you'll learn it later. It's called a circle of Willis, but it's the internal carotid circulation, which turns into this big mess that you guys need to learn about. And so everything else, pretty much, more or less, at least superficially, is supplied by the external carotid artery. The important things that you need to understand, know the major branches. So the really big ones: facial artery, occipital artery, maxillary arteries. They are named for where they are. So think about it. So facial artery covers most of your face. Maxillary artery and maxillas are sort of the medial part of your face, is the best way I can think to describe them. And again, like I said, everything in the back has occipital in its names. So the mnemonic there is for all of the branches of the internal carotid artery until so from inferior to superior on both sides. Once you get to the parotid gland, which it pierces, so the external carotid artery goes through the parotid gland. Technically, once it comes out the other side on the top, it's a superficial temporal artery. So it doesn't look like a branch, but it is technically, that's where it terminates, turns into the superficial temporal. Yeah, so you just sort of have to learn this stuff, but it is hopefully fairly straightforward once you learn it. And I'll again, if you remember what we were talking about with our little mandibular and mental foramens, so you can see our little mandibular canal sitting in there, and allowing our inferior alveolar vessels to go through, come out as our mental vessels. All right, let's talk about venous drainage. So not as high yield as your arterial stuff. I guess the bigger thing for you to understand is the way it's plumbed at the top is different and the way it's plumbed at the bottom is different. So at the top, instead of having everything come to our external jugular vein, your facial vein and your temporal vein, which do follow like the facial artery and the temporal artery pretty well, they don't go to the external jugular vein though. So instead they go to our internal jugular vein and they flow down through there into your sort of SVC subclavian area. We do at the same time, it's mostly your maxillary, your mandibular, and your occipital veins that go through the external jugular, and they go separately. Yeah, that's all I need to talk about. And there you guys can obviously read up more if you're interested. Okay, let's talk about the trigeminal nerve yet again. You guys are hopefully noticing a pattern now with interrupting to talk about cranial nerves every now and then. But it's going to be important for the next bit. So I already talked a little bit about the idea of sensory innervation. So your ophthalmic nerve is going to, well, division of the trigeminal nerve, it's going to be involved in all the stuff around the orbits, around your eyes. And so up here, your nasal area, your maxillary branch, or your maxilla area, and then your mandibular branch. So the sort of boundaries between them are sort of the edges of the nose, and then like the eyes out to the side, and you can almost draw. It gets a bit fuzzy once you get up to there, but like you can maybe argue it's sort of vaguely the temporal fossa, superior temporal line. The lower boundaries of the maxillary territory is basically the jaw, because your mandible, well, is your lower jaw. And so that's going to be supplied by the mandibular branch. And so the first two bits, they're pretty straightforward. The ophthalmic also has a little bit of function with the lacrimal glands, but that's also covered by the facial nerve, so you don't sweat that too much. Actually, I think I've lied there. I think it's pretty much just sensory. And the facial nerve is what covers the lacrimal gland. The other place where it does provide touch sensation is the anterior tooth of the tongue. So we're going to talk about the tongue in more detail later. The thing to understand, I guess the most important thing I want you guys to understand is that there are two different types of sensation that come there. And so one of them is your bog standard norm one, which is touch. So, you know, if you touch your tongue, you put food on your tongue, you can tell that it's touching it. You can tell the texture, that sort of stuff. That is different to taste. So taste is a completely different dimension. And so the nerves that carry those things will often be different. Not always, but they will often be different. And the fibers that carry them will always be different. Okay. So let's talk about the innervation as well of in terms of motor innervation. So your first two divisions don't have any motor innervation that you need to worry about. The mandibular division does, and it's actually quite important. So we're going to talk about the muscles of mastication in a little bit later on. The tensor tympani we're going to talk about when you talk about the ear, but suffice it to say, your eardrum is called your tympanic membrane. So tensor tympani, you can hopefully figure out what that means. And then a few of your basically anterior neck muscles, so just, you know, under your chin, submental, you might say. We get a little bit of innervation there as well. And then your tensor palatis, so that tenses your palate, roof of your mouth, basically. But the biggest thing, I guess, the important thing I want you to take away, muscles of mastication, and we'll talk about them in a little bit. In a little while. So again, remember, our mandibular branch goes down through our foramen ovale. Our mandibular division goes through the maxillary branch goes through the foramen rotundum, and then the mandibular division goes through the foramen ovale. The other thing, again, you'll notice again, like the accessory nerve went up into the skull and out. This is the opposite. So the meningeal branch, it goes down through the foramen ovale, and then it decides, I've had enough of the outside, I'm going back in, I can't deal with it, and it goes up in through the foramen spinosum, and so re-enters the skull. Okay. All right. Okay, let's talk about the muscles of facial expression next. I'm going to talk about the facial nerve in a second too, because this is really important for all these. In fact, it innervates all of them. The groups that I've put on the left, they're not really like formal groups, but they are sort of a useful way to think about it in functional terms. So I'm not going to belabor you with the specific functions of all these things. I'll just say most of them you can pretty much figure out their function by their origin and insertion, like any muscle basically. If I had to pick particular things for you to be concerned about, your orbicularis oculi comes up a little bit, your platysma comes up a little bit, your buccinator comes up a little bit, but really you should just have a sufficient understanding of all of these to be able to identify them. I know you guys are doing dissection as well, so you might be asked to dissect some of this stuff. In the diagram to the right, everything except for the masseter is a muscle of facial expression. The muscle is muscle of mastication, which we're going to talk about in a little bit. So facial expression, they're all involved in facial expression. So manipulating your face, opening, closing your eyes, changing the shape of your mouth, all that sort of stuff. That all has to do with these guys. All right, again, it's time to talk about cranial nerves. This time I'm going to talk about the facial nerve. This is a good diagram. Unfortunately, it uses some sort of very weird names for the types of fibers, so ignore those for a second. We're just going to talk about the types in Monash terms. So Monash likes to use a sort of three-part structure to the name of different types of fibers in the cranial nerves. So the first one is general versus special. So general is boring, old busted. That's all the stuff you've been learning until now. Special is special. So that's basically the stuff on the motor side. It's the muscles that come from the pharyngeal arches, which you'll learn about in the embryology video, hopefully. And so that's most of the muscles in the face region, and some of them in the neck region as well. In the sensory side, it's your senses. So taste, not touch, taste, hearing, balance, sight, smell, all of those things come through special visceral sensory. And so your general somatic sensory, that's your boring old touch. Your general visceral sensory is your afferent sensory, pain, temperature, whatever, from your viscera. Yeah, so in terms of the actual root of the facial nerve, this is important to understand. So what it says internal porus acousticus, we're talking about the internal auditory meatus. There's another diagram on the next page which uses more reasonable words and puts it in a better context. But the important things I want you to understand, the fact that it gives off a few key things. So we have the greater petrosal nerve, which we'll talk about a little bit. And that basically goes forward and innervates a few things. The quarter tympani is another important thing. And so that is going to go and join the lingual nerve, which is coming off the mandibular division of the trigeminal nerve. And so although it comes from the facial nerve, it actually spends most of its time following that one. And so it's important to note the bit where it turns and where it goes through the way. But the bulk of the facial nerve is going to instead travel through it. Punctures or pierces or whatever the parotid gland, and then it separates into a bunch of different branches. Again, ignore the labels here. They're not the formal ones, but you'll see the same branches, but people use different names. The one on the next page is the one that Monash likes to use. And again, the other thing I'll draw, so again, we got lacrimal glands. That's a greater petrosal nerve sneaking up into our little orbital region that we talked about before. Your quarter tympani, we'll talk a bit more about its function in a sec. But the other thing to understand, so again, like I said, there's two things to understand with the tongue. So there's touch, things touching your tongue, textures, all that sort of stuff. And then there's taste. So this guy talks about your taste. All right. So, in terms of the main facial nerve, we've got the internal acoustic meatus, or auditory meatus, whatever you want to call it, goes out through there. We have this big ganglion over here, and then we later on travel through the stylomastoid foramen to get out there, and that's going to give off all of our branches. So the parotid gland hangs out somewhere over here. It pierces those and give out a whole bunch of different branches all over the place. Meanwhile, our greater petrosal nerve. It's going to leave right after that big ganglion. It's going to go forward into our pterygopalatine ganglion. Again, we'll talk about that when we talk about the pterygopalatine fossa. The important thing I want you to understand, your lacrimal gland, or your nerve to your lacrimal gland really, is going to go through there and it's going to innervate that. Yeah. So the other thing to understand, again, the chorda tympani, so it moves off here. It actually splits off in the middle ear, and then it travels over that area through the eardrum. You'll see it again. It features prominently in some of our discussions about the actual ear opening or space or whatever. And then it goes and it joins the lingual nerve. And so it's indistinguishable in course from the lingual nerve. And again, that's pretty much motor parasympathetic. So it's some of your salivary glands, and then it's also your tongue, basically. And we talk about it in terms of the anterior 2/3 and the posterior 1/3. Yeah, perfect. Okay, so these are the branches that you really want to know. Your temporal, zygomatic, buccal, marginal mandibular, and your cervical. Whatever acronym works for you. That's the one I found the most fun and whimsical, or really easiest to remember. You can again see the branching is sort of the same. They've just decided to label it a different way, but this is the way Monash likes. This is not an exhaustive list of the muscles of facial expression. As far as I remember, there's some stuff missing, like the risorius that is innervated by the facial nerve, but it gives you an idea. So in general, your temporal and zygomatic handles your eyes and above. Your buccal handles a bit of that, and also your cheeks. And then as we go down, mandible, obviously, your mandibular muscles, and your platysma, which is a very interesting muscle to flex, goes down the bottom. All right, let's talk about the muscles of mastication. So these are our guys innervated by the trigeminal nerve. Almost all the other muscles in the skull, so we'll talk about the neck, that's a completely different thing. When we do the pharynx and larynx, that's a whole different kettle of fish. But in terms of the skull sort of head region, it's pretty much all your facial nerve and your trigeminal nerve, with a few notable exclusions. But for now, we're going to talk about the trigeminal nerve, the mandibular branch, and they're going to come down and innervate these 4 different muscles. So your temporalis is this big fat one. You remember we talked about the temporal fossa, goes through there and inserts onto the mandible, as do pretty much all of these, but they insert into slightly different places, and we'll talk about that in the summary thing on the next slide. All of them, except for the temporalis, they have 2 different parts that come together to actually form the muscle as a whole. Okay, so here we go. So temporalis comes down to the coronoid process. So remember, I said it's not useless, but it doesn't articulate. So you can think of it as almost like all of these things. They're just like leverage, basically. And so your temporalis uses that to provide leverage to not only elevate but also to retract. If it was just coming to the condylar process, it'd be more difficult, especially because it's a joint, so you can't really rotate something by pulling it into the joint, but it also would be a bit more restricted in its movement. Everything else, it just has different insertions. You can sort of see what's going on here, or at least you can figure out the function again by the origin and insertion. So your medial pterygoid and your masseter, both of them, all they do is they go down to the ramus of the mandible, and then they just move up. So they're basically up to down. They go superior to inferior, and they just raise it up. The lateral pterygoid is more interesting. So it basically allows us to have lateral movement. So, well, go figure. And so if you move them together, you can push your jaw forward at the same time. Or if you use only one at a time and you relax the other one, then it lets you move your jaw from side to side, which is important in chewing. Although more so in like cows and ruminant animals than in humans. Okie dokie. Anterior and lateral neck. Again, most of this stuff is going to be just stuff that you need to memorize and figure out. But I guess it's worth mentioning. It's all pretty systematic. So the suprahyoid muscles, they all sort of have their own, weird little names. The digastric, I will point out because it's another case of the Latin name actually being kind of useful if you know it. So di, gastric, stomach or belly, it is a muscle with 2 bellies. So we have one part that comes from the anterior region, attaches near the chin. The other part attaches much further back. But the point is, all of these suprahyoid muscles, they elevate the hyoid bone, and that makes it easier for you to swallow. Your infrahyoid muscles, they depress the hyoid bone, and then also that some of them help you move all of that sort of cartilaginous structures a bit up and down. You have your scalene muscles off to the side. You can sort of see them kind of arguably here. Hanging out of here. Those are more lateral than anterior, really. They're mostly hidden under the sternocleidomastoid, unless you get a more lateral view of the neck. And they, I think the most important anatomical relevance of that is the fact that we get a couple of important structures. So the brachial plexus and the subclavian artery, they both go right between those anterior and middle ones. And in terms of clinical relevance, so if you're thinking of accessory muscles of respiration, if you're like I was in second year, like, well, what are those though? These are some of them. So, you get your big shrugging of the shoulders and that sort of stuff. Well, not a big shrug. You get movement, basically. Shrugging the shoulders is more just levator, scapula, and all that. Anyway, so posterior neck. You're really familiar, hopefully, with the trapezius. You might be a bit less familiar with the splenius. And then underneath that, we get a whole mess of things. So again, important to, I guess, easier to remember if you think of the deep layer as mostly having to do with the spine, basically. Your deepest layer is even more, so I guess your deepest layer, it's either your suboccipital muscles, everything at the back is called occipital, that, like I said before, they extend the neck, skull, whatever you want to call it, joint. Then your interspinales and your intratransversarii, they are literally muscles that go between parts of your cervical vertebra. And so they're really well integrated there. Then your semispinalis and your multifidus, those ones are also very closely associated with the spine, but they're more posterior. So they're sort of over the back of the spine, and then over on top of those, you get the superficial layer. Okie dokie. If you're tired of muscles, I have good news for you. We're back to cranial nerves yet again. I promised this the last time. So, what I want you guys to understand, well, again, hopefully this is a good reference table, but I think the most important thing to understand here is that some of these nerves are much more complicated than other nerves. And so you can see right now, 1, 2, and 4, dead easy. 1, 2, they do literally one thing. 4, it innervates one muscle. They carry one type of fiber. Again, I think I've talked a little bit already about how to differentiate between the different names. Motor and sensory, hopefully you guys understand by now. General and special is basically, is this a special head and neck thing, or is it everywhere else in the body? So your somatic and your visceral sensory, you've already run into in the thorax and the abdomen. Your special somatic and sensory visceral, it's worth talking about. Sorry, your special somatic versus visceral sensory, important talking about. So your somatic sensory is basically your special somatic sensory, is the stuff that's on the outside. So you can sort of think about it like, okay, so your eyes are on the outside, they communicate with the outside. Your ears are on the outside and they communicate with that. Your sense of smell really has more to do with your inner nasal cavity. And then your tongue obviously hangs out, and all the other parts that have taste. We'll touch on taste a little bit later, but it's worth noting that not only your tongue has taste buds, your palate has taste buds, and your epiglottis has a few taste buds. They're not as sensitive as your tongue though, which is why you primarily taste stuff on your tongue. So again, really 3, it sort of just barely gets away with not being a boring nerve, because it has this little pupillary sphincter, which, dilating your eyes, dilating your pupil. The trigeminal nerve is really the first one to be, properly interesting. Your muscles of mastication, they fall under V3. So again, ophthalmic, maxillary, mandibular, and then your general sensation is everything else. So even though it comes from a lot of different places, you can remember it as this is touch only. So even when it comes from the tongue, it's not carrying taste, it's carrying touch. All right. And then over here we have, again, a few one-note nerves, which we love, which are our friends, the cranial nerve 6, cranial nerve 8, which is just your ear nerve, vestibulocochlear, but really it's just the ear nerve. It does all the things that the ear does, and it does nothing else. And then accessory nerve and hypoglossal nerve, they basically touch a lot of stuff. When I put a dash there, that's like minus, or like not including the palatal-glossus. Same thing with the salivary glands, minus the parotid gland. But then we have our big boys over here that do all sorts of different things. A facial nerve, glossopharyngeal nerve, and a vagus nerve, and all of them do lots of different things. I have underlined all our tongue stuff because, again, it's one of the little sort of needly little bits of the anatomy to understand. Most of this is just stuff that you need to learn. I think really the easiest way to learn it for a lot of this stuff is to understand the exceptions. So remember that the palatal-glossus is not innervated by the hypoglossal nerve. It's the exception. That your stylopharyngeus muscle, unlike most of the rest of the stuff in the pharynx, is innervated by your glossopharyngeal nerve. Just little things like that. That's going to be the easiest way for you to remember this sort of stuff. Yeah, I'll leave the tongue thing for the next slide because we're going to talk about that in proper detail. But yeah. All right, here we go. As promised, extremely quickly. So again, palatal-glossus, we get a little exception there. Again, we get a bit of an exception with the innervation of the glands, because like we talked about before, that whole quarter tympany stuff, so that was coming forward to give off your parasympathetic fiber, so it gets these little ganglions. Specifically, it's called the submandibular ganglion. Then that gives off, remember, because parasympathetic, its synapses are close to the target structure. That's where it synapses. And then we get fibers that go out to the submandibular gland and the sublingual gland under your tongue. The parotid gland is not innervated by those. Parotid is by the glossopharyngeal nerve, but the facial nerve runs through it, and the external carotid artery, like we talked about, also runs through it. That's most important because if you need to get your parotids taken out, they need to be really, really careful, or you can screw things up quite a bit. Yeah, the other thing I'll note here is that we, like I talked about, we have multiple things happening with the tongue. So your motor innervation is going to come from the hypoglossal nerve, which is the which innervates. Like we said here. Oh, did I talk about it? Maybe I didn't talk about it. I didn't mention it. Oh, sorry, there you go. So we talk about the extrinsic and intrinsic muscles of the tongue. So the tongue has a bunch of muscle. It's like a big chunk of muscle in of itself. We have a bunch of stuff underneath it, which is mostly innervated by that, and then we have the intrinsic muscles inside there. So motor, you don't need to worry about too much. It's pretty straightforward. Sensory is a mess. So the first part, there's sort of two superstars of the head and neck, facial and trigeminal nerve, and so your general sensory, your touch, is going to come from your lingual nerve, which is part of your mandibular division of the trigeminal nerve, and then our friend the quarter tympany comes through, and it supplies the sensory innervation. So the taste innervation. So it's a special sensory innervation. Then the glossopharyngeal nerve gets very jealous and decides to hog all of the functions for itself, and so it does sensory and special and general sensory for the posterior 1/3. So we talk about anterior 2/3 and posterior 1/3. And then the vagus nerve handles all the epiglottal stuff. Although importance of the sensory innervation, the special sensory innervation of the epiglottis, it's not really that important. You don't do much tasting through there, but yeah, important to remember this stuff because it does come up. They love asking you questions on this. Yeah, that's about it. So I've left a couple diagrams here that are hopefully more interesting. So not more interesting, more useful, to understand some of the stuff that we weren't able to touch on in this. So this is I really love this diagram. It's from Radiopedia. It's very good for remembering all the stuff that goes through the optic fissures, or orbital fissures, really. This is a different view of the skull that we didn't really get to look at before. It really shows you how the sphenoid works, how the ethmoid works, all of these things. Over here we have, this is going to be more important once you see the infratemporal and pterygopalatine fossa. That's all some general stuff. And our last one here. So this is the facial nerve. We already saw this a little bit, but this sort of drills it down to some of the basic stuff. With the greater petrosal nerve, again, goes up to a pterygopalatine ganglion, and then it gives off a bunch of stuff. Stapedius, that's a stapedius muscle, so that's important to remember as well, that it has that little function there. And then because most of the rest of it is innervating the muscles of facial innervation, and then we have our other important friend, the quarter tympany, and then all of our facial muscles of facial expression. And this is a little bit of arterial supply, which again, probably more useful later on. But yeah, very long video. I hope you guys found it useful, and that you're able to refer back to these slides whenever you need a little bit of help or revision on the head and neck. Again, feel free to send us any questions, and until then, happy revising.